right. We have a couple folks who are still joining us this morning. And so I'm gonna try to work on admitting folks as they continue to pop in. First, to start, I want to thank all of you for being here and appreciate your interest in coming to learn more about this particular topic. When my co-presenter and I were talking about wanting to do a presentation on perinatal mental health or surrounding perinatal mental health, we both thought that talking about perinatal mood and anxiety disorders that occur in non-birthing parents was a really good place to start, because I think sometimes, like even in the literature, a lot of the work, a lot of the research tends to be targeted towards and focused on the person that gives birth rather than the other folks, and the experience, the perinatal spectrum and the perinatal continuum is a very interesting time because there's a lot of identity development that happens during that time. So yeah, we came to the decision that talking about non-birthing parents was something that we felt like was an important piece that we needed to bring some awareness to. So before we get into it, for those of you who don't know me, my name is Dr. Lindsey McCormick, and I'm an assistant professor here in the counselor education department online at the Chicago School. And I'm a certified perinatal mental health specialist, a certified lactation counselor, and I'm also an EMDR certified therapist and approved consultant. And I will let my co-presenter introduce themselves.
Hi, everyone. It's good to see you. My name is Stephanie Leonhardt, and I'm a third-year graduate student in the counselor education department online campus, getting my master's in clinical mental health counseling. I currently work at a private practice that specializes in perinatal mental health.
Thank you, Stephanie. So let's get into it. So as some of the things that we're going to talk about specifically, we're going to look at the difference in various different perinatal mood and anxiety disorders, and some of that symptomology that comes with perinatal mood and anxiety disorders, as well as some of the risk factors for the development of PMADs in non-birthing parents, as well as some clinical considerations for folks who are engaging in practice and might see this walk into your office or show up on your screen. So to start, we're going to start with what are perinatal mood and anxiety disorders, or PMADs. I think one of the things that is important to talk about is this shift from using the term postpartum to perinatal. And traditionally speaking, it is often, even for myself, before I started specializing in PMADs, when someone would have said something to me like perinatal mental health, my go-to would have been, oh, postpartum depression or postpartum anxiety, which it's not to say that it doesn't include postpartum depression or postpartum anxiety, but it's to bring awareness. Using the term perinatal brings that awareness of there is a spectrum that exists all the way from individuals who are engaging in attempting to conceive to the point of parental identity development, which the terms are a bit binary, but the term that we use for parental identity development is matrescence and putrescence. And so there is this idea, a lot of folks who work with that identity development is that matrescence and putrescence, that window of time is generally around 3-ish or so years after that child has been born. But there's folks who say that there's that identity development and parental identity development is constantly evolving and shifting and changing with every pregnancy, with every perinatal loss, with every birth. And so I think that's, as I said a couple minutes ago, I think that's what makes the field of perinatal mental health really interesting, in that there is a constant shift in parental identity and what that looks like for each individual person in this perinatal spectrum or on this perinatal continuum. And so if you maybe don't specialize in PMADs, but start to see and notice within this field, there's much more of a shift towards using the term perinatal than using the terms like postpartum. That's part of the reason why, is because we're attempting to bring awareness and recognition to all of the different mental health experiences that can happen in that perinatal continuum. Nope, Stephanie, you're muted.
Thank you. Sorry about that. So within the perinatal mood and anxiety disorders, there's 6 main ones that are considered. So the first one is perinatal depression, and this includes postpartum depression. It refers to any depressive symptoms that are experienced during pregnancy or within that first year postpartum. Symptoms may include persistent sadness, feelings of loss of hopelessness, changes in appetite, changes in sleep, fatigue, feelings of worthlessness, thoughts of self-harm or suicide, or a loss of interest or pleasure in activities. It's also essential to recognize that perinatal depression affects both mothers and fathers, birthing partners, and non-birthing partners. The second disorder is perinatal anxiety. This involves an excessive worry or fear and can be experienced during pregnancy or after childbirth. Symptoms include restlessness, irritability, difficulty concentrating, muscle tension, racing thoughts, and panic attacks. And it can interfere with daily functioning and bonding with the baby. The third disorder is perinatal obsessive compulsive disorder, or OCD. This involves intrusive, unwanted thoughts or images, which are the obsessions portion, or repetitive behaviors and mental acts, which are the compulsions. And they're usually used to try to reduce the level of anxiety. Common obsessions may relate to harm coming to the baby or fears of contamination, and compulsions may include excessive cleaning or checking rituals. Perinatal OCD is distressing and time-consuming, and it can impact the parental well-being and caregiving responsibilities. The fourth one is post-traumatic stress disorder. So PTSD can occur after any exposure to a traumatic event. In this case, it may be a difficult childbirth or a miscarriage. Symptoms of PTSD may include intrusive memories, flashbacks of the trauma, avoidance behaviors of reminders of the event, negative changes in mood and cognition, and heightened arousal. So it's really important for those suffering with PTSD to provide trauma-informed care and to support those individuals experiencing perinatal PTSD. The fifth type of mood disorders are the bipolar mood disorders. There's type 1 and 2. Bipolar disorder involves mood swings that can range from depressive episodes to manic or hypomanic episodes. Type 1 is characterized by manic episodes that last about a week, or it requires hospitalization, and it's often interspersed with depressive episodes. Type 2 involves recurrent depressant episodes, and that alternates with the hypomanic episodes, and it tends to be a little bit less severe than full-blown mania. In the perinatal period, this can be particularly challenging because of the hormonal fluctuations and sleep disturbances that typically occur. And the last group of disorders are perinatal psychosis. So this is rare, but it is severe. It's a mental health condition that typically emerges within the first few weeks postpartum, and symptoms can include hallucinations, delusions, severe mood disturbances, confusion, and disorganized thinking. So perinatal psychosis requires immediate medical attention because it can pose a risk to both the individual and their baby. So there are a couple common myths that I would like to discuss in the next couple of slides. So the first one is that PMADs are the same as postpartum depression. So currently these terms, PMADs and PPD, can be used interchangeably, and they may in like the medical field, but postpartum depression is a very specific disorder, whereas PMADs is more of an umbrella-like term, and PMADS does include postpartum depression. It also includes like the disorders we just talked about, perinatal depression, so that's throughout the perinatal period, not just postpartum, perinatal anxiety and OCD, PTSD, the bipolar mood disorders, and psychosis. The second myth is that only birthing partners can experience PMADs. So approximately 10% of new dads experience perinatal anxiety. This approximation is thought to be underreported due to kind of the stigma around mental health, and then also mental health with men, and also because they are not the ones that go through the physical changes of having a baby. So there might be some resistance there to think that they may have a PMAD. Additionally, support programs that are available for PMADs are typically marketed to women and to the birthing parent. So this reduces social supports for men because they don't have as much support socially, and that can increase their risk of developing a PMAD or can increase the risk of severity. Non-birthing partners are also at a higher risk of developing PMADs if their partner is also experiencing a PMAD. And they are less likely to use the birthing partner for support because the birthing partner is already going through a lot of changes, and they may also have the kind of responsibility of taking care of the baby and bonding with the baby, especially if they're chest feeding or anything like that. So all of those things can contribute to non-birthing partners or fathers also experiencing mood and anxiety disorders during this time. The next common myth is that PMADs can only occur a few weeks after birth. So like we discussed through the perinatal period, they can occur at any time. They can occur during pregnancy. When they do, they tend to affect pregnancy outcomes. So this can be low fetal weight or even stillbirth, depending on the disorder. PMADs can also occur up to 2 years postpartum. This can affect long-term maternal wellness and child wellness, and it can also impact the family unit functioning. So this can be the birthing partner, non-birthing partner, baby, any other siblings or family that's included, because it can impact the way that the caregiver bonds with their baby. The next one is that there's no treatment for PMADs. So there are quite a few studies that show that antidepressants and psychotropic medications can be used during pregnancy and in the postpartum period, even if chest feeding is the primary source for feeding the baby. There are also a few support groups and a few organizations that put support groups together that have been shown to be effective. And then psychotherapy, primarily ACT, DBT modalities, and the emotion-centered problem-solving approach can be used. And the next myth kind of ties into this one, and is that PMADs will resolve on their own. They may dissolve on their own, but not always. And untreated PMADs can lead to the parental suicide or overdose, increased pregnancy complications if the PMAD occurs during pregnancy, stillbirth and infant mortality, and then again, decreased caregiver-infant bonding, which then can also impact the rest of the family and family functioning. And the last myth is that there's no stigma surrounding PMADs. So stigma is still a barrier to receiving treatment, especially in the broader range of disorders that are included. So postpartum depression is there's less stigma around that, but other disorders that may be lesser known to the general population, there still is a stigma surrounding them. Additionally, certain populations may have increased stigma, like rural people that give birth in rural areas or are a caregiver to a recent baby in rural areas, birthers of colors, and then birthers of color, and then non-birthing partners, particularly men.
So with regards to the literature and the information that's out there specific to PMADs in non-birthing parents, it's not an exaggeration to say that there's not a lot. There's not only is there not a lot, this is a bit of a newer emergence in the field of perinatal mental health. As I mentioned previously, a lot of the work around and surrounding perinatal mental health tends to be targeted towards birthing people, which is understandably so, right? There's a lot of, when we think about the perinatal period, we think about, birth and that experience postpartum. But that's a little bit where the non-birthing parents don't get the recognition or the support that they need within that. Excuse me. So the research that is out there tends to look at perinatal mood and anxiety disorders experienced by cisgender males who are in heteronormative relationships. And then in the small newer research that's out there and available looking at LGBTQIA plus families. A lot of that research is targeted towards like women and lesbian relationships. So that's where a lot of this literature and information comes from and is pulled from. Again, it's emerging. It's something that's continuing to be looked at and by a considerable amount of researchers. But that's not to say like that just because the information is out there doesn't mean that like folks in polypods, for example, don't experience perinatal mood or anxiety disorders. So Stephanie mentioned some of these things already with regards to experiences cisgender males can have in the development of perinatal mood and anxiety disorder. There's a lot of research that's been done and been shown, qualitative data that's shown us that there are times where non-birthing parents feel like they're the less important parent because they're not the parent that gave birth. If their partner is body feeding, they're not the ones body feeding. They don't, there's a running joke on social media about men and their useless nipples kind of thing. And so because of this, this can create this shame and stigma around the fact that cisgender males are the less important parent. And this can lead to a decrease in their self-efficacy with regards to parenting. And we don't have a lot of information about how we are addressing or assessing the mental health needs of those cisgender men who might be experiencing perinatal mood or anxiety disorder. And that was in 2016. That continues to be mostly true. Even so, I live in Ohio, and here in Ohio, there's a practice that started an intensive outpatient program that's a postpartum intensive outpatient that is a bit of at least the first of its kind for the state here, in that it's an intensive outpatient program that you don't have to have a substance use disorder to be admitted to it. It's targeted towards birthing parents, and there's no such program that I know of in this state or the majority of the other states that I'm licensed in that have not only have intensive outpatient programs for birthing people, but have any sorts of outpatient outreach kind of programs in the agency setting that can be supportive for men or cisgender men who are experiencing a PMAD. There are support groups that are run by Postpartum Support International, and they're run by folks like myself who are certified in perinatal mental health, and peer volunteers who run those as well. And there are support groups for men that are virtual in that regard that are hosted by PSI. They're some of the only ones that I know of that exist. And that continues to feed into that stigma and shame, especially if we think about our traditional gender roles and our societal roles, when we look at heteronormative relationships and in parenting, even. And now it's 2024. The landscape for some of those things has changed with regards to, we have both parents who are dual income. We have dual income households, and workers and earners and things like that. So that role shift has occurred. When we look at our gender role landscape, but when it comes to, and even parenting, there's often we've got much more folks who are engaged in much more active and involved parenting roles, with regards to being engaged, being there, and things of that nature. However, we still have this societal stigma of, if you're a cisgender man, the only acceptable emotions are, anger, and you don't cry, and there's not a lot of emotional intelligence, or that emotional intelligence is not that it's not there. It's the display of that emotional intelligence or that emotional awareness that can bring the stigma and the shame. And because of that, this can impact how they engage with their infants. And this also, I think, one of the things that's really important to mention when we think about PMADs and PMADs developing within that 2-year time frame, or the parental identity development of putrescence, and even extending out past that 2 years. Within that time frame, there is the development of parental preference by infants and toddlers, and that sometimes that parental preference goes towards the father. Sometimes that parental preference doesn't. And that feeling that parental preference, even though that is a very normal, common experience and behavior for an infant or a toddler to go through, there can be a lot of emotion that is still felt by that sense of rejection by your own child. And even that, and feeling emotions surrounding that, regarding that, can bring up a lot of shame and negative experiences for folks, which again leads to less self-efficacy, less of what's the word I'm trying to think of here? Less of like thinking less in your own abilities to be a parent. There, I'll phrase it that way. And not feeling like you do have the skills to be able to engage as a parent. And so therefore, that can create conflict between the spouse and that person, the spouse. It can create conflict between the parent and child, simply because, and maybe not simply is probably not the correct or the best term, but there's, again, going back to that stigma and that shame, those feelings, that feeling of stigma and shame that's around surrounding emotion and surrounding feeling less than important, or less important, and not having somewhere to go, someone who understands, or if there is that support that understands, still having a lot of shame in going to those supports, like friends, for example, to have those emotional conversations or to talk about feelings or talk about or get into some of the supports that they need. So in the DSM-5, there were some changes to the diagnostic criteria, like the specifier for peripartum onset. And so when we think about and conceptualize postpartum depression, what that conceptualization is in clinical diagnosis is major depressive disorder with the peripartum onset specifier. And when the DSM-5 was released, that peripartum onset specifier gave us some more inclusion to be able to diagnose male cisgender men with that peripartum onset specifier. The Edinburgh Postnatal Depression Scale, or the EPDS, continues to be the most prevalent, the best screener that we have, and the most widely used screener that we have for postpartum depression and paternal postpartum depression. There was a study that was done in 2019 that was out of Australia, I believe, if I remember correctly, that showed that there was a generally positive attitude for the EPDS to be used with cisgender men. And they found it easy to navigate, read, and for us as providers, as clinicians, the EPDS is really easy to get a hold of. It's a quick online search, or there's, or if you have an electronic health record system, there's a couple of EHRs that have the EPDS already integrated into the system for you to be able to send it to folks, for them to take it electronically and for it to get scored. So it continues to be the best thing we have. And it's pretty straightforward with regards to administration and scoring. And the results have been all over the place with regards to prevalence. But the general consensus with regards to the prevalence rates is that it's probably still pretty underreported, given the fact that there is so much stigma and shame surrounding mental health, surrounding men's mental health. The likelihood that the numbers might not 100% accurately reflect those prevalence rates is highly likely. So some of the risk factors for cisgender men for experiencing PMADs, one of the biggest ones is if their partner has been diagnosed with or is experiencing symptoms of a perinatal mood or anxiety disorder. But you have things like lack of support, unemployment, substance use disorders, previous history of psychotic disorders, and relationship satisfaction, especially if we're thinking about folks who are already in strained relationships, having in the postpartum period, continuing to have strain in that relationship with the addition of an infant. So Dr. Singley is one of the folks that's partnered with Postpartum Support International, that often gives the presentation in there's a couple different ways that they do training for the perinatal mental health certification. And the one that I went through when I had the training on PMADs in men, or PMADs in partners. It was led by Dr. Singley, and he's a psychologist that's done a lot of work surrounding perinatal mood and anxiety disorders in non-birthing cisgender males. So some of the things that he has said that are important for clinicians to keep in mind with regards to treatment and addressing this topic is to make sure that we're continuing to bring about awareness of maternal perinatal mental health. And that awareness can take a lot of different shapes and forms. But the increase in awareness and the normalization of the experience can help to combat some of that stigma and shame that's associated or can be associated with some of those more traditional gender roles. Making sure that we're engaging in screening, that we don't forget about them, that screening for new fathers, screening for expectant fathers is just as important as doing and engaging in the screening for expectant birthers, or new folks who have just given birth. And, you know, we talked about the Edinburgh and using the Edinburgh, but I would also say that just using the Edinburgh in screening, that's only going to screen for depressive symptoms. It's not going to tell you anything with regards to anxiety, obsessions or compulsions, any symptomology related to traumatic stress or traumatic experiences. That's just going to be for postpartum depression. So making sure we're doing screening not just for perinatal depression and paternal perinatal depression, but screening for those other PMADs as well. And making sure that there's continued encouragement or surrounding the engagement with partners, and encouragement in engagement with the new infant too. It's you know, infants don't come with manuals. There's been a lot of folks that have written a lot of books about parenting and the parenting experience and what kinds of parenting there is and things of that nature. But when they hand you that infant at the hospital and you take it home with you, it doesn't come with a rule book and it doesn't come with a manual. So continuing to encourage and enhance self-efficacy around parenting with fathers, with mothers and birthing persons, all of those things can help decrease some of that stigma and shame that can be experienced by having a perinatal mental health concern. So last couple slides here are talking about PMADs in LGBTQ plus families. And with regards to the, like I said, the research in this area, it's very small. There's been some, and one of these articles that I pulled from was a qualitative study that was done by so it was midwives who had done some work on just gaining knowledge about the lived experience of the non-birthing person in lesbian relationships. And there was they reported that a lot of folks struggled around this theme of, I don't know what my identity is as a parent. There's no template for what this looks like. There's not a lot of people that I can model this experience around, or talk about this experience with, because there's just, that's not there, that it's not there, and it doesn't exist in the mainstream, I would say. So because of that, there's a lot of isolation that can come from that. Again, a lot of those feelings of feeling like the less important partner, or the less important person, because they weren't the person who gave birth. They aren't the person who might be engaging in body feeding. And so trying to navigate this identity development of who I am and what my role is in this parenting dyad can be a challenge. And it all goes back to our self-efficacy in being able to parent, in being able to nurture, in being able to provide support, even for like partner support, support for care of the infant, but partner support for what they might be experiencing and what they're going through as well. So some of the implications that have been that have come out of this with regards to folks working with LGBTQIA plus families is making sure that we're continuing to recognize and combat heteronormativity. Just like I said, with the matrescence and the putrescence, like those terms are very binary. But being cognizant and aware of the type of language that we are using, and within the binary, and how some of the language that we use can be very heteronormative. Not only heteronormative, but also can be very binary with regards to gender. So saying things like body feeding instead of breastfeeding, or saying chest feeding instead of breastfeeding, using terms like non-birthing parent rather than, jumping to the heteronormative man or male kind of thing. But the other thing that we need to be considerate of with regards to us being practitioners is that there are a lot of different birth workers that folks are going to come in contact with. Birth workers, meaning not just us who are providing mental health services to folks in the perinatal community or part of the perinatal population, but also to OBGYNs, doulas, lactation care providers, all of those folks. They're all going to have experiences with both those non-heteronormative families and heteronormative families. And so, again, that kind of goes back to making sure that we're using inclusive language, making sure that we are actually providing trauma-informed care, and what that means, what not just saying that we're doing trauma-informed care, we're engaging in trauma-informed care, but actually doing that. Making sure we're, again, engaging in screening, making sure that we as clinicians are continuing to engage in cultural competence and awareness, taking trainings and are a great way to continue to do that. Seeking consultation, seeking supervision. If you are if you're still under clinical supervision, continuing to engage in conversations like that with your clinical supervisor or learn from your clinical supervisor, asking for resources, things of that nature, are all ways that we can promote cultural competence when it comes to working with LGBTQIA plus families. So we have about 10 minutes before the top of the hour. So does anyone have any questions? And if you don't want to come off mute, you can absolutely put questions in the chat. Okay. Thank you. So yeah, if there are no questions, we can continue to so the QR code, that's my digital business card. If you want to scan that, and I've put the contact information for myself and for Stephanie here on this slide as well. With regards to obtaining the credit for this session, you should receive an email from the Office of Continuing Education within the next 24 hours, which will include a link to the evaluation for the session. So once you complete that evaluation for the session, I believe, if I remember correctly, once that evaluation is complete, it will generate your ability to be able to get that certificate for this session today. But I'll stick around. If anybody has any questions, please feel free to stick around. If not, thank you all so much for being here again. And if you're attending anything else at the conference, I hope you enjoy the rest of the conference.